Hi, my name is Tanya Greaser, and I am the Family Services Educator with the Huntington Society of Canada. And I'd like to welcome you to the next session, HD101. This session will provide you with an introduction to Huntington disease, including genetics and predictive testing, symptoms and stages, and research. Leading the presentation are some of my colleagues from HSC's Family Services team: Mart Gautreau, Karina Mason, and Rhonda Romalak. Mart is the Huntington Society of Canada's Resource Centre Director, or RCD, for New Brunswick. She's a registered social worker in Moncton. Mart has worked for HSC since October of 2001. A self-described outdoor lover, Mart adores her early morning walks, as well as baking and spending time with family and friends. Other favorite leisure activities sees her out in the community, going to restaurants and movies. Karina joined HSC as BC's Resource Centre as a family service worker in June 2021. She is a graduate from McGill University with a master's degree in social work and has been practicing in the field since 2016. Karina helps families impacted by Huntington disease navigate resources, provides individual short-term counseling, and facilitates support groups. Rhonda became the director of the BC Resource Centre shortly after joining the HSC team in May of 2017. She has worked with the HD community throughout BC and is one of the social workers at the Centre for HD Clinic at UBC. Rhonda's social work practice includes short-term counseling, group facilitation, and community development. She draws her experience working with patients and interdisciplinary teams in acute care as well as rehabilitative hospitals. Rhonda values the relationships she has built with the HD community and with her team members. And now it's time for HD 101.
Welcome, everyone, and thank you for joining us. I'm going to go over a little bit of the agenda for our presentation. We will start with an overview of the Huntington Society of Canada, move on to genetics, HD symptoms in area of impact, and disease progression. We will cover resources, and at the end, we'll have a question period. The mission statement for the Huntington Society of Canada is to improve the quality of life for those affected by Huntington disease. Huntington disease was first described by Dr. George Huntington in 1872. The Huntington Society of Canada was founded in 1973 by Ralph and Ariel Walker. Huntington Society of Canada is a not-for-profit, charitable, national organization. HSC is governed by a volunteer board of directors. Huntington Society of Canada fundraises for two programs: Family Services Program and Research. Next slide. I want to speak to you about the Family Services Program. We have 15 resource centers across Canada. We offer direct support for families and individuals, provide information and education, offer short-term counseling, referrals to different resources, client advocacy based on individual needs, and national advocacy for systemic change. And when I speak about a national advocacy for systemic change, I want to speak to you about the Genetic Non-Discrimination Act, which became law in 2017, The court system challenged this law, and the Supreme Court upheld the decision in 2020. And since then, a person's genetic information is protected. Huntington Society of Canada. I want to speak to you about research. The goal is to find treatment, reverse, slow down, or prevent HD progression. We have clinical fellowships. That's a one-year clinical training for new neurologists. And the Navigator Award is the 1 to 2 years of funding to support Canadian scientific research. National and regional initiatives. The month of May is what we call May Awareness for the Huntington disease. And during this time is what we are involved with the Amaryllis campaign, which is our major fundraiser actually for the Huntington Society. But during the May Awareness Month is another activity to create awareness, and it's called Light It Up for HD. And there across the country, several major buildings and whatnot are lit up either in blue or in purple to help create that awareness. And also families at times will light up on their own property, maybe their front porch or a tree or whatever, either in blue or purple. The purple is for juvenile Huntington and the blue is for adults. Also during May Awareness Month, we have our virtual National Huntington Disease Walk. Next slide. Sorry, it's the same one. Regional initiatives. We have local chapters and local support groups as well throughout different provinces. And our chapters and families are the heart of the Huntington Society. And national initiatives, we've had, especially during COVID, a lot of different virtual parent support groups and HD and at-risk support groups. We have an online Facebook support group. And another program that's very important is the Youth and Young Adult Mentorship Program. Here, the younger people that are involved with families that have Huntington disease are mentees, and the older ones are called mentors, and we match them up through this program. And Huntington Society of Canada has a commitment that every youth that's a mentee that needs a mentor will have one. So that's a very important program. Next slide is our map here that shows all the different resource centers across the country. You will notice that the larger provinces has more than one resource center. And we also, at different resource centers, there's family support workers and there's RCDs, resource center directors. Every province is part of the Huntington Society of Canada, except for the province of Quebec. They have their own society, La Société Huntington du Québec, and that is mainly because of language. Now I will pass on to the next slide to Rhonda.
So I'd like to start by breaking down what is a neurodegenerative disorder. Neuro has to do with cells in the nervous system, specifically the brain. Degenerative tells us it gradually gets worse over time, and disorder is another word for disease. Therefore, HD affects the nerves in the brain and gets worse over time. Symptoms can mirror ALS, Parkinson's, and Alzheimer's simultaneously. It's important to remember that every person living with HD will experience symptoms and progression of the disease in a different way, even in the same family. Unfortunately, there isn't a cure, but there are treatments to manage symptoms, strategies to help with the changes, community programs, and ongoing research. Although HD is not a common disease, it does impact a lot of people, as you can see by these statistics. It's important to remember that if someone has HD, everyone connected to them is affected by it. That's why our services are available for people with HD, their families, friends, and health professionals. Now, Karina will continue on.
Okay, so we're going to look at the genetics with Huntington's disease. So we're all born with 46 chromosomes, and we get 23 from each of our parents. Our chromosomes are made up of genes, and our genes are made up of DNA. And in our DNA, there are 4 bases, which is cysteine, adenine, thymine, and guanine. And the HD gene is located on chromosome 4, and it's comprised of cysteine, adenine, and guanine, which makes up the acronym CAG. Everyone has the HD gene. However, people with an HD diagnosis have a mutation in their gene, which results in a CAG expansion. So if we look at the graphic, the top half of the image demonstrates what the HD gene would look like that's not mutated or expanded. And then just the second half of the image is what the gene would look like with that mutation or expansion. You can see that it's quite long. So the HD gene mutation is determined by your CAG link. So like I said, everyone has the HD gene. However, unaffected individuals will have a CAG repeat of between 10 to 35, which is in this range right over here. So that means the individual, like I said, has the HD gene, but there's no mutation and will not lead to the eventual onset of Huntington's. For individuals with the CAG repeat of about 36 to 39, so that indicates that there is a slight mutation. However, it may not result in a Huntington's diagnosis during the normal lifespan, or it could result in a very late onset. And then if we look at the CAG repeat of 40 and above, that indicates that the individual will develop HD symptoms in their lifespan. And so although the gene mutation is inherited, the pattern of symptoms is not. So a parent and child who can both have Huntington's disease can display very different symptoms and experience the disease differently, including the age of onset. To determine if there is that gene expansion, individuals may decide to undergo predictive testing with a genetic counselor. And that's a very complicated and personal decision, with only about 10 to 15% of people that are at risk for Huntington's decide to undergo predictive testing. The testing process varies across the country. However, typically individuals after the age of 18 can meet with a genetic counselor through multiple sessions and help process the complicated feelings that arise from the testing process, and also help make the decision to undergo predictive testing at that time. When we look at disease onset, we see that the average person is diagnosed between the ages of 35 to 55 years old. The CAG repeat can give us a sense of an earlier or later onset, but can't exactly tell us when symptoms will begin or what symptoms will be experienced. So typically when someone has a higher CAG repeat, so for example, CAG of 45 or 46, that can indicate a younger age of onset. Whereas, for example, an individual with a lower CAG, so say, for example, CAG 40, that may indicate a later age of onset. But it is important to remember that everybody does present differently. So an individual can have the same CAG as someone else and present with different symptoms. We see about 10% of cases being with a diagnosis of juvenile Huntington's disease, which is before the age of 20. And so that's very rare, and that can also present differently than the adult onset. Sometimes parents can see a change in their child's school performance due to learning difficulties and challenging learning new information, and also have a difficult time retaining information that has been previously learned. We see that about 25% of juvenile HD cases develop epileptic seizures. And instead of the more prominent chorea, an individual may have rigid or slow and stiff muscles. And then finally, at about 10% of our cases with HD is a late onset, which is after the age of 60. I'm going to pass it along now to Rhonda to talk about the different symptoms of Huntington's.
Thanks, Karina. So you may have heard the saying, have you met HD? So as you look at the slide, M is for movement or physical symptoms, E is for emotional or psychiatric, and T is for thinking or cognition. So that's where we get our MET. In the upcoming slides, we'll be speaking to each of these areas in more depth. I think it's interesting to look at it and see each area affected overlaps with the others. For example, if a person has trouble processing instructions, which would be under your thinking, then it may be difficult for them to use a walker. So that would be under your physical ability. Because, for instance, they might not remember to use the brakes. Another example might be when someone is depressed, which would be psychiatric. It can also interrupt your ability to think by hampering a person's attention, memory, and decision-making abilities. So now in our next slide, we're going to start, I'll start off by looking at physical symptoms of HD. One of the most common is involuntary movements, which you may have also heard called chorea. There are unpredictable dance-like movements that affect arms, legs, the torso, and face. They can also impact a person's mobility, which increases the risk for falls. The person with HD may also have decreased coordination, and diminished voluntary movements. So an example of this would be the inability to maintain a position. So if you were sitting, it would be difficult to stay in place, or complete an action such as keeping your eyes closed. Involvement of an occupational therapist or physical therapist can be helpful to assess for equipment such as grab bars, walkers, wheelchairs, and other assistive devices such as special utensils for eating. These recommendations can help individuals remain independent longer. Due to HD movements and the disease itself, a person will need increased nutrition and hydration. To maintain their weight as the disease progresses, they will need up to 5,000 calories a day. So consulting a dietitian can be helpful. Another area impacted by HD is speech and swallowing. Because the disease causes a loss of coordination in the throat muscles responsible for speaking and breathing, you will notice changes such as a hoarseness in the voice, slurred words, the inability to control speech volume, and inappropriate pauses between words. This is called dysarthria. Also, as HD progresses, eating and swallowing can become increasingly difficult. This is called dysphagia. Some examples are coughing and repeated throat clearing during a meal. If you notice this, it's important to consult with your doctor as soon as possible, as it can lead to choking, aspiration, and pneumonia. A speech language pathologist, or you might hear somebody called an SLP, will perform the swallowing assessment, and they will give recommendations such as a modified diet. Because a person with HD may not react to pain in the same way they used to, they may not realize that they have an abscessed tooth, a cut, or a burn. So it's important to look for small changes in behavior or appearance, which can be signs of illness or infection. There can also be an altered perception of body temperature and excessive perspiration. So the person with HD may be hotter or colder than others in the same environment. So they may be dressed differently than others in the room, or be asking for the heat to be higher or lower. Karina's going to continue now with the psychiatric symptoms of HD.
So it's just really important to remember that each person with Huntington's can present very differently, but we do see that some of the mood and emotion changes can be some of the first symptoms noticed by people with HD or by their family members. And the research suggests that some of these symptoms can be observed even 10 years before a clinical diagnosis of Huntington's. We see on average about 33% of individuals will develop a psychiatric symptom as their first sign of HD, and overall 73% of people with Huntington's will have at least one emotional symptom. So due to the changes in the brain, we can see unfamiliar personality changes arise, and more specifically, some psychiatric symptoms include apathy, which is a lack of initiative or a lack of motivation, anxiety, which is intense and persistent worrying, mood swings, such as irritability, perhaps a short temper, impulsive, OCD, which is obsessive compulsive disorder, and depression. So depression is the mood disorder that is most commonly experienced by people with Huntington's, and it's characterized by a persistent and sad and anxious mood, overall loss of interest in things that had previously brought joy, low energy, possibly feeling restless, withdrawing socially, feelings of hopelessness, and thoughts of death or suicide. So it's really important to be aware of the signs and know that there's support to help navigate this process. There is medication that is available to help improve the quality of life. So it's really important to consult with your GP, the HD clinic, or a psychiatrist to determine the best course of action. I'm going to pass it along now to Mart to discuss the cognitive symptoms. Mart, you're muted, I believe.
Yeah.
Mart, I believe your mic is still muted, sorry.
Okay, sorry about that. Okay, cognitive symptoms is the thinking, unseen symptoms. What's affected is the short-term memory and the retrieval of a memory. verbal fluency, and word finding. A person's ability to think, learn, remember, concentrate, complete tasks, follow instruction, gradually becomes affected by the progression of the disease. It's difficult for them also at this point sometimes to initiate a conversation. So it's important that we initiate a conversation with them. It takes more time to process information for the person that's affected with Huntington disease. For them, sometimes it's difficult to find their words, to put their words together, and to process the information that they're receiving. So it's important that when we speak with a person with HD at some point, not to speak too fast, to slow it down, to give them a chance to respond, because we may ask a question, and while they're working hard at trying to put their words together to answer that question, we may be already starting the second question. So if we give them time, they will be able to answer. But we need to slow down. Also, because it's difficult for them to process all this information, sometimes it's important when we change topic, just to let them know that now we're going to change topic. It's difficult also for them to multitask. So, so just to keep it slow. Difficulties in making decisions. Sometimes they have poor judgment. Problem solving could be an issue, or reasoning. That perseveration can stay on the same topic for a long time. Maybe it's repetition or have a narrow focus. Also, they lack self-awareness of their symptoms and their limitations. I've seen someone that had a lot of movement, and in speaking with the person, realized that they don't view themselves with the movement disorders that they have. They don't see it. Also, a person could be rigid in their thinking. So some people may refer to them as being stubborn, but it's part of the disease. They're not necessarily stubborn. It's just the way it is. It's just, or they're stuck on something, right? That perseveration. And it's hard to negotiate with a person with Huntington disease at sometimes. A person may be confused, may have an altered sense of time, and we need to manage our expectations when we work with people with Huntington disease. And I know at times that can be quite frustrating for families, but that's what we need to do, is manage our expectations. Now I'm going to speak to you a bit about the parts that are unaffected. Recognition memory. They can remember someone that they met a long time ago. And when they see that person, several months later, they still remember that they've met that person. Their long-term memory is very good. And that's why, they'll remember things maybe from their childhood. And I've met with families where their children would say, my father talks to me about stuff that happened before I was born and don't even know, sometimes what he's referring to, what he's talking about. So we need to explain to the family as well that the short-term memory, maybe they don't remember what they had for breakfast, but they can tell you what happened, 15 years ago or whatever. Language comprehension, even though they lose sometimes at some point the ability to speak, they understand everything that's said around them. And they know what's happening around them, and they know what's being said at all times. So that's important to remember. And also that every person with Huntington disease have different symptoms, as Karina mentioned earlier, but even within the same family, I had, people, siblings, they don't have the same symptoms within the same family. Now I'll pass it on to Karina.
Okay, so we're going to talk a little bit about disease progression. So the diagram identifies the different stages of the disease of HD progression. It's important to remember that HD does progress slowly over time. And each person will experience this differently. So we'll start with the prodromal, which is just on the far left, right over here. And this is the period which is 7 to 10 years before an actual diagnosis. And this is when we start seeing some of the changes that I described earlier, and some of the neurocognitive signs. So perhaps an individual is having a difficult time at work, with their maybe processing information, maybe they're feeling a bit disorganized, perhaps they're experiencing maybe some emotion symptoms like depression or anxiety. And this is really before we get the diagnosis. Between the prodromal and the early stage is when the individual may have some minor movements. They're likely able to continue working, driving, and living fully independently, but this is the stage where we see some of the more movement symptoms start to take effect and the person has an HD diagnosis. In the intermediate stage, the individual is likely no longer working, perhaps needing assistance in different activities of daily living, or perhaps needing some assistance with finances and household management. And the person may also have some more movement at this stage. And then finally, in the advanced stage, so this is the stage where a person will need assistance for most, or if not all, assistance in activities of daily living. So assistance with hygiene, eating, meal preparation, personal care. At this point of the disease as well, we'll see some swallowing and communication challenges and either severe chorea, which is the movement, or very stiff and rigid muscles. What's important to remember is that the Huntington Society Family Service Team really can accompany families throughout this journey and help adjust as new stages emerge. And we can also help connect the family and individual with local resources. I'm going to pass it along to Rhonda to discuss more in depth our resources that are available.
Okay, so I think throughout we've really tried to talk about that HSC is here to walk with you through the journey. So I think support early on ensures you are receiving current and timely information and help. At the beginning of our presentation, Mart shared information about our family services program. And please don't hesitate to reach out to one of us in your area. We're available by phone or email, and all of our contact information is on the Huntington Society website. Of course, being followed by a medical team is very important. There are movement disorder clinics and HD clinics, where you may be connected to a family doctor and a neurologist, depending on where you live. These medical professionals can provide symptom treatment and referrals to occupational therapists, physiotherapists, and speech and language pathologists. Often, they're also the first avenue to learn about research and clinical trials. Exercise is so important for our physical and mental health, and programs can be adapted as the disease progresses for a person. So exercise doesn't have to end, it just needs to be a little bit different. Organizational suggestions, like using reminders on a cell phone and visual cues like notes on the bathroom mirror, can be really helpful. It can remind a person to brush their teeth, wash their face. So think about what might be helpful in your situation, and other people in the HD community can share things that work for them, or also as workers for Huntington Society, we have recommendations if you need to. Support groups and conferences like this are a great way to learn from a variety of people, including others impacted by HD. Because of mutual lived experiences, you don't need to explain what HD is, and they can share ideas and suggestions of what has worked and what won't work. Good communication is always key. Be open, become informed, talk about HD. We all require support from others, even though sometimes we have to go outside our comfort zone to reach out for it. Future planning can be a difficult topic, but we all need to do it. By planning for our future, it allows us to make choices and maintain control over how our future will unfold. So again, this is an area that the staff can help with, because each province may be a little bit different. So again, if you talk to somebody in your province, in your area, we can help walk you through the steps. And that's the next slide.
So just an additional few resources that can be really helpful to take a look at. For the latest information with the Huntington Society, we have the Horizon newsletter, which is the national newsletter that comes out twice a year. If you're interested in getting some more information on Huntington's disease, our website also has a number of different brochures and fact sheets with so many topics, from the cognitive changes to juvenile Huntington's to general information on Huntington symptoms. So it's a really great resource for families in general. The carer's guide and the physician guides are in-depth resources for caregivers and medical professionals, with lots of information on disease progression and very detailed information on the different symptoms. We touched on them today, but like we said, there's so many specifics and differences across each person with Huntington's disease. So if you're looking for some more detailed information, that's a great resource. And then for information on research, HD Buzz is a website with the latest information on research, and it's written in a language that can really be understood by the community members. Lastly, our website has information about getting connected with the local resource center directors and with our family services team. So we would definitely be happy to hear from you and to walk you through this process in getting some more information. All right, thank you.
Thank you, everyone. I think we'll open it up to questions now for the speakers. We do have a few, and I'll go through them, and feel free to answer. First of all, one of the questions that we have is, can HD skip a generation? Karina, how about we get you to answer that one?
Sure. So typically, no, we don't really see HD skipping a generation. And my colleagues can jump in and add more if I'm missing anything. But for when we see what maybe seems like HD has skipped a generation, sometimes that can also just lead to a very late onset of symptoms. So it doesn't look like the person maybe was getting diagnosed in the range of 35 to 55, but we see it maybe in their 50s or 60s.
And the other way too, sometimes we notice is if somebody dies pre-symptoms. So we wouldn't know if they have not had testing, if they didn't do predictive testing, and they've not had symptoms, and their death is prior to that, then it might appear that we've skipped a generation, but it's just that we didn't know that that parent had HD. So there'd be, the next generation wouldn't have that knowledge.
That's a very good point. Thank you. Thank you, Karina and Rhonda. Another question that we've had, is there anything that I can do to slow the progression? Mart, would you like to take that one?
Sure. Not that you can necessarily slow the progression, but for sure, like if for anything, if we take good care of ourselves, for example, if we have the amount of rest that we need, hours of sleep, eat well, exercise, take good care, like have a healthy lifestyle, if you like, and that certainly will go a long way. So it's just to be good to yourself and take care of yourself. That will certainly help. To say that slows down the progression, I can't really say it slows it down, but for sure it's all to your advantage, right? Put everything in to your advantage, and that'll certainly help.
Yeah, it makes me think of quality of life too, because as your disease progresses, maybe we can't stop the progression, but if there are services or medications that can help, you can maintain a quality of life and more independence.
Right.
Wonderful, thank you. Another question that we've had is, what symptoms do people with HD first start to have?
So I can take that one. We touched it briefly in the presentation where we see the prodromal stage, which is when an individual is just pre-diagnosed with HD. For someone to actually get an HD diagnosis, there has to be the onset of that motor movement, so some chorea, but it may not be something that is impacting them greatly at that time. Sometimes we can see some of the emotion and mood changes being the first indicators. So it really depends on each individual.
Follow-up question to that is, if your parent has a certain symptom to begin with, do you also have those same symptoms to begin with?
No,
Yeah.
I think I can answer that one. Even like you don't necessarily have the same symptoms your parents had. Like I had said earlier, like even within the same family, you don't necessarily present the same symptoms. So even it's hard to say, like if a parent started, it goes by the CAG repeat to say a little bit, when you're going to start showing symptoms and whatnot. But if your parent had a low CAG repeat number, maybe, it's possible from your mom that maybe you'd have a low CAG repeat number as well, but you wouldn't necessarily have the same symptoms.
Okay, thank you. How about, does someone with juvenile HD have the same life expectancy as someone with adult onset?
I can answer that.
Oh, sure. Go ahead, Mark.
With juvenile Huntington, it's the progression of the disease is faster, and usually a person with juvenile Huntington, the life expectancy is shorter than an adult.
And with juvenile Huntington's as well, when we see the CAG repeat is often very high. So what we see often for someone who's diagnosed in the adult age, so in the 35 to 55, they may have like a CAG anywhere from like 40 to 45 is what we can commonly see. With juvenile HD, the CAG count can be significantly higher than that.
But if it's someone that starts showing symptoms even as a child, like very young, that's the group that I was talking of, that the progression would be faster and their life expectancy would be shorter.
Okay,
Yeah.
Wonderful, thank you. Someone here has posted that they've just been diagnosed and they're wondering where to start to look for support. What's the best way to get connected?
So I think if you can connect with somebody in your area. So as we think about that map that we had in the presentation, there's resource center directors and family services workers across the country. So I think it's always a good place to start there. And it's always interesting whether you're gene positive or you have an HD diagnosis, because that's a little bit different. I think that it's always a good step to have a medical team and to have some support through Huntington Society.
Wonderful. A follow-up question for that, Rhonda. Are there local support groups or people meeting now that we're moving out of COVID?
Each province has different support groups, and most of us might have a combination, I guess, since COVID. So, I mean, one of the silver linings of COVID was that we are doing a lot of things virtually now. So for us in BC, we can reach a lot of areas, smaller areas that wouldn't necessarily have an HD-specific support group. So we do have that, but there are some provinces and some areas that are starting to meet in person for support groups. And that can be support groups for people with HD, care partners, and we do have some national support groups too that are virtual. So lots to access for people.
Okay.
And if they're interested, all that's on our website. And I think aren't you doing you are also doing a booth visit, Tanya?
Yes, that's right. There is at one of the booths. There's a support group booth that you're welcome to log on to, and I'll be there to answer questions specifically about that as well. Thank you, Rhonda. A couple more questions have just come in. Are there any benefits to having predictive testing done when there isn't a cure for the disease? And with a follow-up, can anything be done pre-symptom to help maintain a good quality of life long-term? How about we start with the first one? Are there any benefits to having predictive testing done since there isn't a cure for the disease?
I would say the best resource if someone is looking to explore getting predictive testing or not is to really connect with a genetic counselor to be able to discuss the whole process. I think a lot of times it's a very complicated decision. I think that there's only like anywhere between 10 to 20% of people who are at risk for HD get predictive testing. So it really depends on sort of where you're at in your life, the type of support that you have, what having that information will do for you. Some people like to be able to plan ahead and to organize themselves. Others would prefer to wait until they're starting to be symptomatic. There's really no right or wrong, but I would encourage anybody who's interested in exploring that process to consult with a genetic counselor for that.
Wonderful, thank you. So then the follow-up question to that is, can anything be done pre-symptom to help maintain a good quality of life long-term? So I'm guessing that is if you've been diagnosed but are pre-symptomatic, is there anything that you can be doing?
I think Mart spoke to that a little bit about just staying as healthy as you can. So it's kind of like having a good foundation. And I know, whether that's through nutrition, exercise, and just addressing things as they come up, whether it's symptoms or mental health, can help for sure. I know one of our doctors at the clinic always talks about the importance of exercise, having a stronger body.
Okay. I think that's great advice. We've got another question here from a Quebec resident, and she's actually considering moving back to Ontario just to access possibly some extra resources. She's wondering where she should start with the move. Is there any connection between HSC and HSQ? Can anybody comment on that? Mart, you had initially...
Not necessarily a connection, but it's like anyone that would relocate like that in Ontario, for example, then you would try to contact the nearest resource center where you're moving to, right? And you would be, and then you could tell if you gave permission to the resource center directors in Ontario to get her, her file. Maybe if she has an open file in Quebec, maybe some information that could maybe be transferred that would follow her, because the way it works with Huntington Society of Canada, the file belongs with the client. So if somebody moves anywhere across the country, the file would follow the client, right? So I would assume that in Quebec, if it's an active client in the Société Huntington du Québec, they would transfer her file to wherever she moved to, right? With the client's permission, saying that she wants her file to be moved, because the file usually belongs to the client, and it should follow the client.
Right. Okay. So, given that she hasn't moved yet,
Right.
she could start some pre-action by connecting.
She could speak with her social worker at the Société Huntington du Québec and let them know that she's planning on moving. And once she knows the location, have them, transfer her file over to the new resource center director, social worker that would be following her.
Okay, because they are two separate entities, and
Right.
they
we have a
don't.
good collaboration with the Société Huntington du Québec. Like if I do some French presentation, for example, it's like, they're good at sharing their PowerPoints in French, and they attend our national conferences as well. So yeah,
Excellent.
kind of help each other.
Excellent. Okay.
Yeah.
And just as a follow-up a little bit for you, that any national efforts on connecting the two, your best bet would be to contact the national office to find out how to do any advocating or connecting on that part to connect the two agencies together. So connecting with the national office is where you would start first off.
And the other thing, if I just add a piece, is some people like to consider where there's clinics. So, you know, is it important for you to be closer to like either a movement disorder clinic or a Center for HD clinic? That way you've got more specialized services. But there's other ways if you're not close to access that, like you would be with a family doctor and a neurologist. So just thinking of some services that way too that you might want to access either now or down the road might be something to consider.
Excellent point. Okay, so I think we're about ready to wrap up. If anybody has any last questions or any last comments that speakers that you want to make, we'll get to that, and then we'll wrap up and carry on. Anything further from anyone? Okay. So I want to thank everyone for coming. I hope you learned a lot about HD from this presentation. Thank you so much to our speakers. It's a good one to share with others who don't know the basics, and we will be posting the recordings after the conference. So feel free to share with family and friends and anyone that you know that needs to know a little more information or to watch again for yourself.